Hello, everyone. This is a recording of a talk that I gave at the United Kingdom Swallowing Research Group meeting in Birmingham in February 2024. And I'd like to thank the UKSRG for the invitation to deliver this talk as part of a panel on the evidence regarding the use of thickened liquids in the management of dysphagia. As with all of my presentations, I'd also like to begin by acknowledging the members of my team at the Steele Swallowing Lab at the Kite Research Institute in Toronto. And I do have some disclosures as shown on this slide. Here it is probably most important for me to highlight the fact that I have a past and ongoing consulting relationship with Nestlé Health Science, and also the fact that I played a role on the board of directors of IDDSI, the International Dysphagia Diet Standardization Initiative, from 2012 until December 2023. Notwithstanding those relationships, I'd like to emphasize that my perspective regarding thickened liquids is grounded in my personal experiences as a clinician. In fact, it was my frustration with the fact that we seemed to implement thickened liquids and pureed foods as a generic default intervention for dysphagia that led me back to pursue my doctorate in 1999. And as you may be aware, understanding how bolus consistency influences swallowing physiology and function has remained a focus of my research ever since. When talking about diet texture, it's important to align on the use of terminology. So for clarity, when I refer to thickened liquids in this talk, I'm referring to liquids that are thicker than a thin liquid. But this consistency may include liquids that are naturally thick, as well as those that are commercially thickened or have been prepared using a thickening agent. And the degree of thickness of those liquids may vary. It's important for me to acknowledge here that this definition aligns with the definition of thickened fluids in the recent position statement issued by the Royal College of Speech-Language Therapists in the United Kingdom, which was the reason for the invitation to participate in a panel about thickened liquids at the UKSRG meeting. I'll also mention here that when I use the term diet, I'm referring to the comprehensive construct of all of the foods and drinks that are provided to a person, and not just to the food side of their meal plan. The other term that I believe we need to align on is the term dysphagia, which may mean different things to different people and does not, in fact, have established diagnostic criteria. When I use the term dysphagia today, I will be referring to a condition in which physiologic impairments in swallowing or oral processing lead either to airway invasion and or to poor bolus clearance through the pharynx. And I acknowledge that this definition is focused on the oropharynx. And as you will see at the bottom of this slide, I believe that the primary goal of dysphagia management is to identify interventions that will optimize or restore both safe and efficient swallowing. When we consider interventions, we are obliged to consider the ethical principles of autonomy, beneficence, justice, and non-maleficence. And today, I want to particularly draw your attention to the definition of beneficence on this slide, where we read that our job as healthcare workers involves a duty to refrain from maltreatment, to minimize harm, and to promote good towards patients, and that we should demonstrate this by providing a balance of benefits and risks to the patient to promote informed decision-making. Now, when I graduated as a clinician, I certainly understood that thickened liquids had a role in preventing aspiration, but I also knew that they were supposed to be reserved for use as an intervention of last resort, recognizing the fact that they are not palatable for many people. In fact, research over the past 20 years has taught us a lot more about the potential negative impacts of thickened liquids, and I think we all recognize that it does not follow that if a little thickening is a good thing, then additional thickening must be better. I would like to propose to you an algorithm for clinical decision-making regarding diet texture modification. Specifically, I propose that the clinical recommendation for thickening liquids is something that should be considered when a clinician has identified a safety concern with thin liquids. That is, their assessment suggests that the patient has penetration or aspiration on thin liquids. A second condition is that other information about that patient suggests that penetration or aspiration represents a risk to their health. And relevant factors here include things like overall health status and immunity, including frailty, mobility, and comorbidities, oral health, and the ability to perform oral care independently, overall level of independence, including for activities like feeding, respiratory history, and prognosis. And third, I suggest that a recommendation for thickened liquids should be grounded in prior, ideally high-quality research evidence, suggesting that thickened liquids are likely to be effective for reducing occurrences of penetration aspiration in similar patients. And I will return to this condition in a moment. Additionally, I propose that a recommendation for thickened liquids should be contingent on an assessment that suggests that there is a positive response to a given degree of liquid thickening with respect to reducing occurrences of penetration aspiration, and also on an absence of evidence that suggests that there may be negative outcomes to thickened liquids that amount to a contraindication. Failure to identify another intervention that is likely to work equally well or better for reducing occurrences of penetration aspiration, and confirmation that there is no known objection or advanced directive on record suggesting that the patient and their family may be unable or unwilling to accept a treatment plan involving thickened liquids. And this last condition implies our obligation to discuss the plan with the patient and the family to ensure their consent. So let's return to the question of research evidence suggesting that thickened liquids can be effective, which was my assigned topic for the panel. Here you can see a pyramid representing different levels of evidence, which I assume will be familiar to most of you. At the top of the pyramid, we can see systematic reviews and critically appraised syntheses of other studies. At the bottom of the pyramid, we find expert opinion, of which there are many sources today, including lectures, textbooks, editorials, opinion articles, blogs, podcasts, social media, and narrative reviews. And a very important question for us to ask is, where do clinical practice guidelines and position papers fit in the levels of evidence? Certainly, clinicians look to clinical practice guidelines and position papers for guidance with the expectation that they are grounded in high-level evidence, as suggested by this version of the pyramid, which places such guidance documents at the very top. There are, in fact, established definitions in medicine of what clinical practice guidelines should be, namely systematically developed statements that assist practitioner and patient decisions about appropriate healthcare for specific clinical circumstances, and which include recommendations that are intended to optimize patient care, that are informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options. And there has been considerable effort in medicine to establish guidance regarding the development process for trustworthy clinical practice guidelines. The expectations here are listed on the slide, and I want to highlight the bullets inside the box, which emphasize that trustworthy guideline development involves establishing a multidisciplinary guideline development group, conducting a systematic review for qualifying evidence, and then establishing evidence-based foundations for stating and rating the strength of recommendations. This is no small task, but unfortunately, as we heard from the representative of the Royal College of Speech-Language Therapists at the meeting, the RCSLT decided not to undertake a systematic review process, when considering evidence and developing their position statement. And their college is not alone in making that decision. Now, systematic reviews are quite common these days, and many systematic review methods documents, including those published by the Cochrane collaboration, manage the enormous task of filtering the evidence by placing limits on the search strategy, such as the decision to focus only on randomized control trials. With respect to the effect of thickening liquids on aspiration and other negative sequelae of dysphagia, imposing this sort of limit quickly reduces the field to only a handful of articles, dominated by 2 papers reporting the results of a study led by Drs. Logeman and Robbins that has become known as Protocol 201. In part 1 of that project, a very large sample of 711 adults with Parkinson's disease or dementia was enrolled, based on evidence of at least one occurrence of aspiration across a probe that involved a series of 6 thin liquid boluses in video fluoroscopy. Individuals who were enrolled then consumed boluses of mildly thick and extremely thick consistency, as well as swallowing thin liquids in a chin-down position, with those 3 interventions organized in blocks that were completed in a random order. The results showed that at least one intervention was effective for preventing aspiration in half of the sample, and that the greatest reduction in aspiration was seen with the thickest liquid consistency. I might just point out here that the authors used the terms nectar thick and honey thick that were in common clinical use in the United States at that time. And a common misunderstanding of this study is the assumption that the honey thick liquid in that study mapped to the moderately thick level of the IDDSI framework. In fact, information in those studies regarding the viscosities of the nectar thick and honey thick stimuli suggests that the nectar thick mapped to the mildly thick range on the IDDSI framework, while the honey thick liquid was exceptionally thick and most likely mapped to the extremely thick level of the IDDSI framework. Now, part 2 of the Protocol 201 study followed 515 of the original participants who were randomized either to consuming thickened liquids or to consuming thin liquids and using the chin down position for the next 3 months. A very important detail to note here is that 2/3 of these participants had in fact continued to show aspiration across all 3 of those interventions in part 1. And at face value, this might lead you to speculate that if it's true that aspiration leads to pneumonia, then the authors might have seen respiratory complications in as many as 66% of these participants. In fact, the investigators predicted a 20% incidence of pneumonia as an expected background rate of occurrence over 3 months in the study population. But the results showed about a 10% incidence in both the individuals randomized to the chin down position and those randomized to using thickened liquids as a group. So I'd like you to think about whether you think that finding shows an important reduction in pneumonia rates compared to what had been expected or not. It's important to recognize that the study was actually terminated early due to recognition that the sample size of 515 participants was actually underpowered to yield stronger statistical results. However, the 10% incidence finding of pneumonia usually gets lost in discussions of this study, given the surprising finding that within the thickened liquids group, pneumonia rates turned out to be twice as high in the extremely thick group, that is around 15%, compared to those receiving the mildly thick liquid at around 7 or 8%. To me, evidence that pneumonia rates may be higher in individuals consuming extremely thick liquids represents compelling evidence that chronic aspiration of thickened liquids is not a good thing. And I believe this finding points to the critical importance of conducting thorough assessments to obtain evidence that suggests the effectiveness of thickened liquids and rules out evidence suggesting that there may be continued aspiration on those thickened liquids before they are recommended for a patient. Now, returning to the question of evidence regarding how bolus consistency impacts swallowing, it turns out that there are actually lots of systematic reviews on this topic and about the effectiveness of thickened liquids for preventing negative health outcomes. And 5 of those reviews are listed on this slide, but there are others as well. In the interest of time, I will summarize these by saying that the first 3, which are all iterations of a review conducted to support clinical practice guidance in Denmark, all focus on Protocol 201. And the searches in those studies found very little additional evidence in the form of randomized control trials, and certainly not enough additional evidence to shift the conclusions by any meaningful degree away from the findings of Protocol 201. The Danish reviews conclude that there is insufficient evidence to suggest that texture modification improves long-term outcomes with respect to the negative sequelae of dysphagia, including pneumonia. Now, frankly, it does not take very long to check clinical trials registries around the world to determine that there are no undiscovered, large, randomized clinical trials of the effects of texture modification on long-term outcomes underway or not reported. And I personally think that the exercise of conducting more systematic reviews in attempts to find additional evidence to answer that question are not a good use of anybody's time. However, I do think that there is potential benefit in looking beyond randomized controlled trials for other types of evidence showing whether or not thicker consistencies are effective for reducing penetration and aspiration. And that was the focus of the final 2 reviews on this slide. You can see that these reviews considered a much larger pool of studies, and they concur in concluding that thicker consistencies do reduce penetration aspiration compared to thin liquids. But these studies also raise the possibility that there may be a safety efficiency trade-off such that thicker consistencies have the potential to lead to greater residue. I can tell you that our literature contains many, many cohort studies and case control studies that have been performed since 2012, which is when the search strategies for those 2 systematic reviews concluded, in which patients with dysphagia have swallowed boluses of different consistencies, either in a single assessment or in pre- and post-treatment assessments, from which we may be able to extract additional evidence regarding the impact of bolus consistency on swallowing to help inform our clinical decision-making. And I want to share just one example from my own research with you, which is a study currently in press. This example is an analysis of the frequency of penetration or aspiration across different liquid consistencies, including data synthesized from 2 studies that I led for Nestlé Health Science. Those studies were not designed to look at the effects of bolus consistency. In fact, they were about evaluation of a novel device. But as part of the data collection protocol in those studies, all of the participants swallowed 6 boluses of thin liquid, and then at least 3 boluses of mildly thick liquid and moderately thick liquid. One of the studies also included extremely thick liquids. And in total, then, the combined data sets comprised video fluoroscopy data for 8,185 boluses from 678 adults with suspected dysphagia. And last year, I approached Dr. James Borders, who is a recent doctoral graduate from the lab of Dr. Michel Troche at Columbia in New York, and asked him to collaborate with me on a Bayesian model statistical analysis of these data, which explores not only the worst score seen in each participant for a given consistency, but takes into consideration the frequency of penetration aspiration across repeated boluses of each consistency. And the results were very clear. The probability of penetration aspiration scale scores of 2 or higher was greatest for thin liquids and it reduced significantly with thickening to the mildly thick consistency. Further reductions were seen with moderately and extremely thick liquids, but these were not statistically significant. The forthcoming manuscript also includes a separate analysis of an additional 3,457 boluses from 177 participants in my own NIH-funded research over the past 8 years. And in that work, we also included the slightly thick level of consistency. And the results were similar, showing a significant reduction in penetration aspiration with mildly thick liquids as the first level, showing a therapeutic effect compared to thin liquids in that study population. In summary, our current evidence base contains a substantial amount of evidence, both from clinical trials and from other study designs, showing that thickened liquids limit aspiration. On the other hand, we lack convincing evidence that thickened liquids prevent pneumonia. And here the evidence is limited by the availability of data from sufficiently powered randomized controlled trials. What is available suggests that chronically aspirating thickened liquids appears to increase the risk of negative outcomes, while at least some proportion of individuals with dysphagia do appear to tolerate known chronic aspiration, and those tend to be the people who are otherwise medically stable and lack the other predictors of pneumonia that have been described in the literature. When considering this evidence, I do believe it is very important for us to be cautious about generalizing findings across different medical etiologies. So how do we move forward? I propose that we need to address both the research gaps and the clinical practice gaps that exist in order to honor our obligations to minimize harm and promote good outcomes for our patients. And I am not personally convinced that it is either feasible or ethical to propose large randomized controlled trials exploring the effectiveness of thickened liquids for the purposes of pneumonia prevention. The decision to randomize study participants to any condition where there is some existing evidence of a heightened risk of negative health sequelae is something that must be scrutinized very carefully from an ethical perspective. But I also strongly believe that clinicians can do more to collect better assessment evidence to inform their clinical decisions. And that brings me back to the algorithm that I proposed earlier in this talk, which I hope might be a helpful tool for promoting reflection and discussion regarding current clinical practice and identifying opportunities for doing better. Thank you for watching and for the opportunity again to contribute to this panel at the UKSRG meeting.
Welcome back.
I can hear you.
Yes.
Thank you very much.
Okay.
I apologize. I don't know what that was about.
No problem. No problem. I'm glad you're back. Okay. I don't think you were the only person having this issue. So thank you for coming back. I just shared the published paper on the chat, and we'll get right to the questions if you don't mind.
I would be happy to do that. Yeah.
Perfect. Okay, so the first question is, in some settings where SLP is not available, is it common to have nurses doing a bedside swallowing test of thin liquids, for instance, to determine when to consult SLP? And if this is the case, should TOR-BEST be used?
Okay. So this question is really asking about a very first step in looking to see whether a person may have dysphagia that requires assessment, which in many countries is called a screening as opposed to an assessment. There are many different versions of screenings described in the literature, of which the TOR-BEST is one, and there are others, also the Yale Swallow protocol and others. Some of them only use water, others use more than water. I don't think it would be appropriate for me to make a recommendation for any one of those tools. What I will say is that they are not an assessment. They're not comprehensive enough as the basis upon which you can make treatment decisions. Their purpose is to decide first of all, whether there is a potential risk right now that such that intake should be restricted, oral intake should be restricted until an assessment can be obtained. And secondly, who needs to be referred for those more detailed assessments.
Excellent. Thank you. Moving on to a next question. What is penetration aspiration compared to aspiration?
Sure, that's a great question. So in the world of dysphagia assessment, we describe the degree of airway invasion using different terms. And the word penetration is usually used to describe material entering the larynx. So it's into the top of the airway, but it stays at or above the level of the true vocal folds. And aspiration refers to the situation where material goes further below the true vocal folds. I usually put the two of them together and call it penetration, aspiration. To me, the fact that material is getting into the airway at all is the first level of an indication of risk. I should say that a small number of healthy people occasionally show penetration with thin liquids, but it's a level where the material dips right into the airway and then is immediately ejected back out of the airway, so it doesn't stay there. That's a penetration aspiration scale score of 2. And we usually don't consider that to be a sign that is clinically concerning.
Great, so I have a perfect follow-up to that. As a dietitian who does dysphagia management at my facility, is there a way for us to discern whether a patient is experiencing penetration aspiration using only clinical bedside exams?
Not with good confidence. So I would say that the limitations of this question are twofold. The first is that you may see a person coughing or clearing their throat after they swallow, and we usually consider that to be a sign of potential airway invasion. But it's not always indication of airway invasion. In fact, some recent discussions are suggesting that there may be other things that cause people to have this kind of response, including in some cases residue low in the pharynx could trigger that response. So it's not a perfect sign. And then on the other hand, we know that there's some percentage of people who do aspirate whose sensory mechanism is also impaired and they don't produce those throat clears and coughs. We tend to call that silent aspiration. And so you may see a person at the bedside who isn't showing any signs, who may in fact be aspirating. And that's really the thing people are most concerned about, is that clinical bedside exams lack the ability to detect that in some percentage of cases.
Great, thank you. I'm going to pull this question up because this is a familiar face to us that we met at the Kuala Lumpur ASHA IDDSI Festival from Satish, who is working on 3D printed dysphagia foods. I don't know if you remember that, Dr. Steele.
I do.
So he's asking, are there any viscosity standards handbooks?
Interesting. So what I would say is that we historically used to use viscosity levels and numbers to define different degrees of thickness for dysphagia management. It's a challenging thing to do that because viscosity is not, viscosity for many fluids is not constant. It doesn't have Newtonian properties, so it can vary depending on the circumstances. And so this is one of the reasons that IDDSI moved away from viscosity measures as features that would characterize the thickness of different levels of fluid used in dysphagia management and moved to IDDSI test definitions of flow. So I would say no, there are no widely accepted viscosity numbers or definitions that are based on viscosity for dysphagia management.
Great. Thank you for attending, Satish. It's nice to hear from you. I'm changing gears a little bit. Back to your study, Dr. Steele. Of the 658 individuals, were there any that were diagnosed with disabilities?
It's a little bit of a challenging question for me to answer. The first part of that study or of that manuscript drew people from 2 clinical studies that involved people with dysphagia of different etiologies, heavily neurological. I don't know quite what the questioner is including under the heading of disabilities. To my knowledge, these were all either neurodegenerative diseases or stroke or brain injury kinds of conditions rather than congenital neurological conditions like cerebral palsy. So no, I don't think that study in particular doesn't specifically speak to people with developmental disability.
Yeah, great. If you are interested in kind of providing a follow-up to that information and that question that you submitted, please go ahead. For now, I'm going to change gears.
I might just editorialize there just for a moment, Alan, and say that it's quite common for people to ask, what's the evidence about dysphagia or aspiration in a certain type of medical condition? And quite often when we go to the literature, we find that there's hardly anything. And so very often we are extrapolating from other conditions, and we have to ask ourselves, does that extrapolation make sense? And so that would be an important question to ask there.
Great, thank you. Besides pneumonia, are there other sequelae of aspiration that have been studied? And I think that they're providing a bit of context, given that the lungs have mechanisms to clear out what is not supposed to be there. Have or should other issues be studied?
Well, in terms of the respiratory consequences of material ending up in the airway, there are different types of respiratory consequences that are described. So there's pneumonia, there's also pneumonitis, and those describe different kinds of responses. But the questioner is absolutely correct that the lungs come with mechanisms for clearing the arrival of foreign material. And so that mechanism may be impaired in some of the patients that we're working with. What I would say is, if we go back to Protocol 201 that I mentioned in the lecture, they looked at health outcomes in people who were known to aspirate downstream, and they included in their study things like dehydration as an outcome, urinary tract infection, so quite a number of health consequences that they caught in their second study. Those may not be directly related to aspiration, but they're comorbidities that occurred in this kind of patient under the study circumstances. And they're therefore important things for clinicians to know about.
Great. Thank you. This is a question regarding flow tests. I am familiar with flow tests, but not viscosity numbers that Dr. Steele mentioned based on questions. Is there an example of a quote-unquote viscosity number that someone could show?
Sure. So viscosity is a property that describes the resistance of a liquid to flow under stress. And I mentioned a few minutes ago, there are sort of 2 general categories. There's Newtonian liquids that have a constant viscosity. Water is a good example. it has a constant viscosity of 1, essentially. And then there are non-Newtonian liquids that have varying viscosity. Historically, in dysphagia management, we use, in North America, we use the terminology nectar thick, honey thick, and pudding thick or spoon thick liquids to describe different degrees of thickness. And viscosity numbers had been proposed for those levels. So thin liquids were numbers of 0 to 50. Nectar was 51 to 350. These are in units called centipoise or millipascal seconds. Honey went from 350 up to 1750 and then beyond. The challenge with that, from IDDSI's perspective, when we were looking at developing guidelines, was that none of us clinically have access to the instruments that are required to obtain those measures. And it's actually a very complicated test to run to get an accurate number. And so it was difficult to imagine situations in which hospitals or even the producers of commercially available products would be able to demonstrate compliance with those kinds of standards. And so we moved away from that towards flow tests.
Great. Thank you. We have a follow-up to the algorithm proposed. Someone's saying the algorithm proposed makes sense clinically. Do you feel that it could be applied to pediatrics as well?
Yes, I do. Absolutely. I hope it is not age specific. I think that the principles that I tried to outline there should apply across the lifespan.
Okay, I'm going to wait for a few more questions to come in. So just a reminder that you can do that using the questions button on your panel. While I wait for that, I will bring up the recording once again, Dr. Steele, because folks are asking to see the last slide of the recording, which I believe is where you were sharing
the algorithm?
your Instagram.
The
Instagram. So I think, give me 1 second. Let me try and share that.
Steele Cycling Lab is our Instagram handle.
Great. Let me just pull that up real quick. There we go. Okay, so so again, I'll repeat that the recording will be available on the IDDSI YouTube channel, and thank you to Dr. Steele for sharing the recording with the IDDSI community as well. So there are no slides to be shared at the moment, just the recording.
I can send a handout of slides that I provided at the UKSRG if that would be useful.
Yeah, that'd be great. Thank you. And then I'll make sure that it's included also in the follow-up that people will receive after the session is done. Maybe we'll do a couple more questions if you don't mind. Okay, if sites don't have a way to confirm aspiration, how can we avoid overuse of thickened liquids?
That's a very challenging question, and I should say that the access to instrumental swallowing assessments, by which I mean video fluoroscopy or endoscopy, varies, of course, across the world. It's probably best, and the access is probably the best in the United States. Here in Canada, it's very patchy, if I'm honest. And so there are many clinicians who work in facilities that don't have easy access, who rely on clinical bedside swallowing examinations. These will not pick up every person who is aspirating, and they may also over-identify suspected risk. So this is where I think it's very important to look beyond the actual observation of swallowing behaviors and to take into consideration the patient history, what you know about their condition, I think people need to be observed over time. And you can take some educated, informed risks together with the patient's consent to try moving beyond what you think is the safe zone to try a broader variety of consistencies. And if that doesn't turn out to yield adverse events within a few days, then I think as clinicians, we need to listen to that evidence, and we need to then support the patient to maybe go further than that calculated exercise. So it's challenging. It takes consideration of many factors. And some patients, particularly those who are otherwise medically stable, will do quite well with expansion of diet texture. But there's always somebody who doesn't do well and is particularly fragile or vulnerable in that situation. And so it's something you have to probe and arrive at your recommendation with as much evidence as possible.
Okay, and we're going to do one last question, and then I think we're going to end it there. Do you know of any upcoming research regarding the correlation between pneumonia and thickened liquids?
I don't know of any studies currently ongoing, but this is a really interesting question. So one thing I'd like to mention is that there have been some studies in animal models where the investigators have actually delivered different liquids, including in some studies thickened liquids, to the lungs of experimental animals, and have explored the degree to which those particular liquids and that direct force aspiration situation leads to negative outcomes like pneumonia. It's very important when reading that literature to recognize that these models are models of chronic exposure to aspiration, so they don't speak to the risk that is associated, for example, in a calculated and carefully observed exposure to liquid in an assessment in somebody who is either already aspirating or has a new problem. So I think it's important not to overreact to that literature, but that literature, to the extent that we understand it, does show that thicker things, when aspirated, lead to worse damage. Also that acidic things can lead to worse damage, and fatty content can lead to worse damage. So those are things to keep in mind. And there's also some concern that has been raised in a couple of papers about people who may aspirate thin liquids and produce a cough, who then, when they aspirate thickened liquids, appear to lose that cough. That's actually addressed in the article I mentioned with James Borders. It occurs in a very small proportion of people, and there could be a number of things at play there. But I don't think it is enough evidence for us to be frightened about testing thickened liquids in our non-instrumental assessments.
Excellent. And we are going to finish there. So
Okay.
Thank you to Dr. Catriona Steele for joining us today. Apologies for the little audio hiccup there, but it's always so lovely to have you back at IDDSI.
Thank you.
And thank you to everyone who attended today. A reminder that you'll get an email shortly with all these resources that Dr. Steele generously has provided for us. And so stay tuned to your email, and hopefully we will see you at our next event. For now, thank you very much again, and hopefully you'll have a fantastic evening. Thank you.
Thank you, everybody.
Bye-bye.